recording in progress for the purpose of having this available for everybody at any time. So on your time. Thank you everyone for joining us on this continuation of the capacity building. In this case, we're going to focus on the QIP project. We are welcome you and thank you for the time that you dedicate to us and to your agency, improving the quality of care for your patients or clients. We have Sonia, our director, in the line. Sonia, do you want to say some welcome words?
Oh, just good morning, everybody, and thank you for being here. We're extremely proud of our CQM team and how far they've come. So please engage with them in this session today.
Thank you for your leadership.
Yep, and thank you for our recipients to be willing to participate and be the stars of this show. Thank you. Jamie?
Yeah, so we'll move on. We've got our standard Zoom rules. Good morning, y'all. What we want to do to kick off, as Michael was talking about springtime in New York, if you could enter your name and organization and a favorite springtime activity in the chat room. For me, I think one thing I love about spring, moving down to Atlanta, there's so many more flowers and blooms, and it's really a season. Here, the pollen too much, but it's really an actual season here. And then I love getting to go with my dog, Miles, on walks. So as folks are putting their favorite activity in the chat room, just keep some of these options in mind. Please try and mute yourself. And then when you're ready to chime in, feel free to unmute. We are monitoring the chat, so you can interact with questions or comments there. And of course, we love to see your faces if possible. And we're just really looking forward to a fantastic return to care session. I'm going to kick it over to Regina to go over some of the tagging and breakout pieces.
Awesome. Okay, so once you join the session, the CQM staff will be renaming you. So we're not going to rename you, give you a whole new name or anything, but we'll be adding your agency name to your name today so we can add you to help us assign you to the appropriate breakout session. If you'd like to add your additional pronouns, you may do so. We encourage that you do. And then if you get disconnected and rejoin, the CQM team staff will also add it back on for you. Next slide, please. And then once we get to that point for to do our breakout sessions, you'll be tagged according to your group, and then you'll receive an invitation like the image there to the right-hand side, and you can just click on join. I know we are all familiar with this, but we just want to make sure for those who may not have known that you'll be invited to the breakout room. And then once you're in the room, you'll within your session, then when the time is up, you'll be notified and asked to rejoin the main room. Sometimes it may just suck you back in, and sometimes you can just click on the link. All righty, and let's see. Our next slide will be our learning objectives. Go ahead, Mike. Is that Michael?
Jamie.
Jamie.
Thanks. So yeah, Angie will be doing some renaming and setting up those breakouts. So thanks, Angie. So what do we want to get out of today? What we want to do would be to describe what are the expectations, both at the subrecipient organizational level and then at the AA level, our level. What are those expectations this year related to return to care? We definitely want to explain and talk and give time to the idea of transfer of knowledge and how that's essential to work that's focused on health system strengthening, which is what we're doing through return to care. And also it's essential when we work with these social determinants of health. We're going to revisit and go back to describing just a little bit that model for improvement. And we want to talk about where each of your organizations are in the stage based on where you're at with the return to care project. So specifically, we're going to focus on that S and that A. We want to explain how do we synthesize data? How do we kind of summarize the tested change ideas into usable data for discussion, which is part of that study, part of that S. And then we also want to talk, how do we actually act or take action on those tested change results? And that's the A, which could be adapting what you tried, abandoning it and going back to the drawing board, or adopting it as standard practice. And so finally, we also want to provide you with some goodies today. So with all of our capacity building series, there's sort of this participant toolkit. So you'll get these presentation slides, and we have two fantastic guest speakers with us today. You'll get our January regional cross-cutting report. We're going to have an action planning form, and then we have different ASQ articles to support the concepts and conversations we have this morning. I'll turn it over to Michael.
All right, thanks, Jamie. And it's 11:10, so we have about 20 minutes to work our way through this part of the conversation before we flip over to our guests. So I'd like to start off just by talking a little bit about our QIP expectations, just to make sure that the left hand knows what the right hand's doing. And in terms of thinking about where we're at, there's two different types of paths that we have since this is a continuation year. We have some folks who are continuing to implement the changes that they set up last year, or they may be tweaking changes and continuing to work through the existing process and change ideas that they had identified. And for other folks, who are making a pivot, we're in the middle of a discovery process. Once again, where we're looking at the information available to us to identify how we want to act related to return to care in this next year. And so it's one of the reasons why we have our guest speakers today, is to help encourage all of us, even those of us who are implementing changes. I think, will benefit from hearing about the social determinants of health, and also the implementation of Continuud in Indiana, to help them with the way that they're working. But for those of you who are making a pivot, this is definitely a time to have all your attention and antennas up, so that we can hear about opportunities to create change ideas and tests of change that really focus on return to care and addressing clients' concerns. So again, we have two paths. Some of you are continuing from last year, others of you are pivoting and going through a new discovery process with root causes, and then you'll be implementing change later this year. The dates that we see here, similar to last year, are when we are having our events. So we have our April 28th event today, obviously, because it's 28th, but then as we work through, we'll have a capacity building session roughly every other month this year, culminating in the poster presentation that'll happen just after World AIDS Day. So in terms of just making sure that we're all aware of what we're doing and expectations, last year folks were pretty good at submitting the QIP form and the PDSA worksheet. And I know that several of you did do the action planning forms, but we designed those forms from an evaluation standpoint and also from a process facilitation and development standpoint to really help you to think about the next steps from one webinar to the next. And so we're actually going to require that this year, that folks submit that to us, just so that we have that opportunity to have a touch point with you. Please don't look at it as another requirement with like boring old paperwork. This is legitimately a way that the CQM team can find those opportunities to provide you specific TA. The QIP form is great in that it tells us what data you're collecting incident to the project and change ideas as they roll out. The PDSA worksheet is great because it's telling us about what you're actually doing with your process. But what we realized is that there's not structured opportunities for you to really ask for help and for us to engage with you concretely on your CQM process overall as it relates to your QI project. So the capacity building form is something that, as Jamie noted, we've always provided through every single webinar, actually even going back to 2020 when we started with you all. But now it's going to be required just so that we have that additional touch point. So since we have sessions in June, August, and October, we're going to be looking to collect those forms from you at the beginning of the month so that we have enough time to chase after any missing forms and create breakout groups and framing questions for breakouts that are really meaningful to where you're at. It also, of course, then creates that additional opportunity for us to provide you with the support that you may need as you're implementing change in the field. For December 1st, that's going to be, in preparation for the poster session. We won't collect an action planning form then because you'll have the action is basically to create your poster. So we'll be looking for your posters. The session that we did in January was super successful. So we're hoping to repeat that, and we're hoping to broaden the net also of stakeholders outside of just our group who could come to this webinar and hear your amazing work and see your posters and the dedication you have to the community. So we are looking to go even bigger and better this time for the poster presentation. So this represents a small shift, but it's a little bit more structure, and it's structure that's designed to help us help you. So I want to spend a moment talking about the organizational assessment, because as you know, this is a big aspect of the way that we evaluate ourselves at the AA level and evaluate all of you at the provider level, the sub recipient level. And so just a reminder that if you scored 3 or less in the 2021 review, we're really needing you to score at least a 3 this year. Otherwise, you will receive a finding. And we have a lot of different documents that can help to crosswalk that conversation for you to help you understand what specifically results in what specific type of finding, because we're aware that your compliance officers and leadership will have those questions and concerns for us. But as it relates to the quality project, it's super important, right, that we're making the strides to actually do excellent work, to do quality improvement projects that will hold water and be meaningful in the end. Otherwise, we're just wasting time and energy, which none of us have either of those to waste. We can't afford it. So let's be impactful here. So just a reminder that your participation in this project by coming to these sessions, by participating actively in conversations, specifically the breakouts, submitting the forms that I just literally showed you we're expecting of you this year, is the best way to avoid a finding and to pull your score up to a 3 if you didn't have a 3 at the time. For domain D, this is the domain that is focused on quality improvement. And so just a sense of how this pans out. We're looking for your QI initiative at your organization to be founded on the analysis of data. So the discovery process, that's why we have that form shaped that way for you, so that you can show us just in response to something that's an expectation that pulls you up. QI initiative should focus on process of care using official QI methods. Again, our processes are rooted in the model for improvement. And so we're going to assume that that's the QI process you use, especially if you can talk intelligently about how you've done a discovery, root cause, generated change ideas, and you have multidisciplinary QI teams that involve a fair share of the staff. Next, your QI initiatives are regularly documented and shared with QM committee. Hello, forms. That's one of the reasons why we created the forms the way we have and have the specific prompts that are included. And this issue specifically about how we work with the QM committee and how we implement our QI teams really is, I think, one of the things that we're trying to advance the ball for our network this year. And one of the reasons why specifically we've required the action plan this year, because that's where we ask questions about how you engage specific type of people. What people you try to engage, and what are some of the ways that you work around barriers. So that's going to be key to our support of you this year in terms of how we're trying really hard to make sure that everyone gets to a 3. This is not us shaking our finger at anyone. We're waving you over the finish line to come with us. Look at it that way, please. For the QI initiatives, that, you know, again, they should involve cross departmental staff, depending on the project and whatnot. So this is just a quick summary and review of really what we're looking for this year. And I see Victoria has her hand up, and I'd like to just take a moment to answer your question, Victoria.
Okay, I have 2 questions.
Go for it.
My first one, maybe a dumb question, but
No such
where
thing,
do
my friend.
we find our score? I must have missed that in some of the conversations. Question number 1. And question number 2, I was looking for Regina's email, which I just found with the new dates for this year for reporting, and was curious. Yeah, I don't see it on here. So one of the challenges everybody knows for us was getting those LPAP and retention numbers. It was our understanding that everybody was aware, and we thought we were only submitting for the final quarter. We did, by mistake, submit viral suppression. That was my fault. But we did manage to submit for the whole year, but it's an incredible burden for us to submit those kinds of numbers. So number 1, so now that we've moved to viral suppression, it's still kind of the same problem. But we at least have a process now. So my question is, and my second question is, for the LPAP retention, there was not a definition provided in that original, and we talked about that in one of the meetings. So I was hoping to get a definition for this year for LPAP and viral suppression, and maybe it's coming, maybe it just hasn't been updated yet, because I know the form that we had last year had 3, 4 or 5 pages. I can't remember. It was much more extensive. So I just want to make sure that before we submit in June, that we understand exactly what you're looking for on that. So that was a question. Then my other question is, where's that assessment where you get your score?
Yeah, so these are all issues that we should be focusing on in the external CQM committee, because your critical feedback and pushback definitely is something that should be driving our system, that we should be working collaboratively with you in the field. But to answer your question about where to find your score, these are documents that were sent individually to agencies within 2 months or so of the OA process last year. So it's probably marked sometime summer 2021 or fall 2021.
Oh, okay. That's why. I was not
sis,
doing this.
Don't worry, we got you.
Well,
when
I
it
need
comes
to know what our I need to know what our score is, though.
Well, 100. But what we got you, in terms of thinking about how we'll circle back and re-forward the emails to you when we're all trying to implement, because we do want to have individualized discussions with you to make sure, again, we're really upping the ante in the type of support we're providing. And if folks aren't able to meet with us, then at least we tried. That's
okay. That's okay. I'm like, I have no idea what he's talking about with a score.
Yeah, you're like,
okay.
Piper posted a chat, a note that's look for an email in February 2021 after on the attachment. So,
well, yeah, I'm not sure that that's when everyone got audited, but for ours, I think we were one of the launch groups, and we visited, with Michael and the Dallas, Ryan White CQM team, and then a couple of weeks after, they got us feedback, and like we walked through. You probably walked through the entire OA sheet with the CQM team. So it's just an overview of exactly what you reviewed in that audit.
Yeah, Victoria, I think it was emailed to you on June the 3rd is what I see.
So did it come to me or did it go to Natasha?
It came from Jamie and it went.
Because I was not in place with the quality committee until late summer.
This is a group TA call, so I'm going to, we're going to be able to handle this offline. And I'm sorry to cut the conversation, but I want to make sure that we're having a conversation that benefits all right now.
I get that.
And I really appreciate these questions, Victoria, because your other question was really important too regarding definitions and what
because we got a letter. Yeah, we got a letter.
There will be notices coming out individually to each agency in response to feedback tomorrow about what specific measures and the definitions for the measures. And that will be part of the individualized conversations that we have with sites, or the offer anyway, that we can have a discussion with you about that. So we look forward to that. And thank you for your questions.
Let's go back to QIP.
It's up. So, we understand that like now we're using the word finding, and like the specter of it came up last year, and we know that spooked Victoria's hand right up. She was like, finding who? Score where? So please engage us on this and believe us when we tell you that we're here to support you and to help you come up with situations that will work for you when it comes to the organizational assessment score. We talk a lot about the things that we want from you, but of course we're also trying to emphasize a lot what we're doing too. So there are our AA level activities, and we want to be transparent with you in terms of how we're trying to support you through the project. So the sharebacks of QIP forms and PDSA worksheets is something that we're looking forward to doing on an ongoing basis. And the data that you submit to us will be shared back in future webinars. This one had some folks submitting one form, other folks submitting another form, and that was a communication issue that we've already discussed via email on us. So there's not updated data here. We're just going to rely on the reports that we submitted to you all in February. And so that's what's going to be in the toolkit, the February report. In the future, we'll have real data. then in terms of how we use the action planning forms, like I already mentioned, that this is going to be a source of our TA provision to you directly. So we're going to be mining those and having conversations internally as a CQM team about how best to support you. And also maybe even trying to create linkages amongst you when there are high-low performers, or when there's a couple of folks that are kind of in the same spot and needing to advance together. But we'll be talking about that all with you individually to see what works best for you. The creation and delivery of this specific capacity building series is no small task. The provision of individualized TA based on those OA results, especially those related to the QIP, the use of data, and the functionality of your teams. And finally, the completion of our own OA and then enhancement to the system structures and processes. And, you know, for those of you who participate in the external CQM committee, you know that we actually spend a lot of time trying to massage these issues with you, as we were just doing with Victoria now. So we look forward to continuing these activities. And of course, if other needs bubble up as we are working our way through, we'll be excited to discuss those and add them to our overall agenda and our methodology here. So why, what is the model for improvement? Again, I think that we know it, but the more important thing is, where are we in the process? So we have a couple of folks that are going back to the drawing board somewhat in terms of trying to do a shift in their QI project. And I did my best to look at the forms that were submitted to estimate. I think that we have 3 agencies that are making significant changes. And most of the rest of us are in a place where we're going to continue testing our existing change ideas or tweaking the change ideas that we already created. So we have ASD, legacy, and legal, going back to do a full discovery process. And most of us are going to continue to use our data to identify how best to implement change ideas or to adjust change ideas as they are coming out. So this is really just a quick flash of where we're at with various projects. It's really important as we're working on this. This is a drum that I've been beating a lot. And what is a system of profound knowledge? A system of profound knowledge is rooted in knowledge transfer, and the idea that knowledge transfer is key to both sustainability and a happy workforce. This has to do with the idea that I can go to a conference or to a capacity building activity like this and then share back with the rest of my team members who didn't have a chance to go. That can be in writing, that can be in a team meeting, that could be, kind of in a Q&A, that can be in a, here I'm gonna stand here and just talk for 5 minutes to kind of unload to you everything that I thought I got. Sometimes when you go to conferences or to meetings like this, like for example, we have the toolkits with all of these different types of articles. You might create a file library or a journal club or some other discussional opportunity for people to really sink their teeth into this matter. I think one of the things that's challenging in coming to a capacity building like this is you're like, it wasn't a bad event, but not all the slides and content spoke to me and to my agency. So it's not like I'm going to ask everyone in my agency to go watch the video. Well, what do I do with this stuff then? How do I make it meaningful for the people that it needs to be meaningful for? So, the idea of creating some of these discussion groups is a way to add meaning, and you add your own personal spin to what the content is. It also allows you to call or to curate, cherry pick different resources among the many that we share that will actually speak best to your audience, to your folks in your own home agency. And so there are a couple of really, really, really important applications to this work that I'm sure will kind of resonate with us to the, and our hearts and minds and anxiety. But when you do this type of system of profound knowledge and knowledge transfer, it really helps because it's a basis of cross training, which then leads to cross coverage. Oh my God, if COVID taught us anything, it's that our staff can be pulled by leadership and thrown somewhere else. And then we're left to pick up the pieces. The other thing COVID has taught us is that mask or no mask, washing those hands or not, people are going to get sick. And some people are sick for months. Still, people are sick for months sometimes. So like, what do you do with that? You can't not have a case manager for 6 months, you know, and I know that you all know that. And I know that some of you have absolutely struggled with that big time over the last couple of years. And it's really incumbent on us to have processes in place to make sure that that ain't gonna happen, you know, or the moon would have to like, you know, be really on the dark side and all of our case management staff got sick, you know, to like totally wipe out the ability of cross coverage here, which could also happen because, you know, chance and the universe. But I think it's really important for us to be purposeful in how we design our teams, how we allocate tasks, and how we have opportunities for cross coverage. This is also really important from a quality assurance principle of peer review. Having peers who also are working with similar clients look at each other's notes and provide critical feedback to each other is a really important evaluation tactic, especially as we start getting into super sensitive areas, talking about things where people have high thresholds, low thresholds of vulnerability and shame, because we're talking about the sex, drugs, and rock and roll that are the reasons why they're here today. We're talking about discrimination that may have traumatized the pants off of them. You know, so it's really important for us to have that support internally in our organizations to be able to look at each other's notes and provide critical feedback about how conversations can go. A lot of time, and I've noticed it's not just a Dallas issue, this is a system-wide issue, but the CQM staff within organizations, and many of you are just a team of one, or you're a team of, oh my gosh, this is 1/4 of what I do, and 3/4 of me is responsible for something else. So to even say CQM staff is a stretch and is a little disingenuous to the amount of effort and stretch that all of you on this call must feel from time to time. So, you know, we often act as these instigators or conveners to ensure information flows freely in organizations. But this is where, thinking about the OA again, where leaders can really help you. Your leaders should be saying, hey, I can only see your eyeballs above the water. Are you drowning? And how can I help you to spread this information? You know, is there an opportunity that I can take someone from the admin staff, a different admin person, to help with this type of capacity building, with this type of sharing of information and the diffusion of innovations within our organization? That's literally why that's under the leadership part of the organizational assessment, because it's literally what the visionary leaders are supposed to be doing. And I think that it's great that the CQM staff, we take that on ourselves, but we should be looking up and expecting / demanding the support of the people above us to help make this happen, or else low OA scores. While projects are in motion, the project team acts as a knowledge transfer mechanism across multidisciplinary teams. And and that's natural, right? Because we have multiple people from case management, from the front office, from the back office, and maybe our CMO who are on a project team. And that by itself, by the nature of the change idea being tested, is how that shakes out. It's really important that the coach and the coaching credibility and the leadership of the CQM team is emphasized with this as well. So when the CQM team is like, hey, we're going to institute a new change idea, we have a new QI project team, hint, hint, this is another opportunity for leadership in the organization to be like, we can't wait for all of you to work with the CQM team, instead of creating interference for the CQM team that, well, I know that you have a project, but they're too busy with something else. That results in low OA scores.
And Michael, Julie mentioned something in the notes, but for those who didn't have the chance to read the note in the chat, Julie, would you mind to explain that for the Part B perspective, please?
Oh, just going back when we were talking about the organizational assessments and when you were sharing the expectations for the year, I just wanted to share that we follow the same pattern with our 6 administrative agencies of Texas that lead the various regions across the state. It's a slightly different tool, but very similar, just a little bit refined for Part D programs at the state level. But anything below a 3 will also expect some corrective action planning with follow-up. So sounds like we are on the same track, and that's totally what we're looking to do, right? So great to hear.
Teamwork
If
makes the
anyone
dream
has
work.
questions about that, we're happy to answer at this state as well.
Thank you, Julie. We really appreciate your leadership and support and the collaborative relationship that we have with you. It's a beautiful thing. Okay, so I'm running behind time, but I'm gonna cover this slide because I think it's really important that we manage entropy and we manage aim creep when we're thinking about our QI projects. This is one of the reasons why you know, we're asking folks to potentially redo the discovery instead of to just kind of go halfway back on the drawing board. Don't do that. If you have accomplished your aim, make a new aim. Don't weirdly kind of roll your aim out using a rolling pin. It doesn't work that way. And it's going to confuse people within your organization and other stakeholders when you try to talk about what the results were. So it's important, I think, to have a written out process that encourages accountability and also creates internal controls, you know, for the quality improvement project. So if you don't have lack of close control, then that leads to variation, waste, and other work and redo. So, you know, if you have a whole bunch of visionary people in your organization all working in individual buckets, then they're going to go in different directions. And you need to have leadership to really help make sure that people stay on the same page and are moving together. If not in lockstep, at least in a line. Entropy really is natural, and it can be harnessed to streamline your quality improvement project also. So in other words, thinking about how people who are passionate and thoughtful and follow their intrigue are going to have a popcorn popper of all of these different possibilities, you basically can create bumper lanes for people to be able to join the conversation and to use parking lots to keep these other kind of peripheral ideas, you know, on the table so that people are heard. But you know, you're really trying to keep the direction going in the direction that's been established. Another thing that you can do with this written out process is to create what we call scaffolding that allow people to climb up into the project using low bars. If there's not training, if there's not proper support, then when we talk about quality with people, especially in the absence of a system of profound knowledge, their eyes glaze over and they're like, what? Especially when you start adding the data and they're like, no, who is he, what now? So it's really important that this scaffolding is, we think about this in terms of how we're supporting people to become involved. You can't just go, hey, there's a new QI project in town and you're going to be on a QI team. Shove, enjoy, next. That's not going to be successful. You really need to think about, like, how do I orient people to this? And how do I make it so that it's not like pulling teeth for them to do this? And then lastly, leaning into the energy and the passion of the broader staff. You know, this is again how you manage entropy. Give the people what they want. They're saying, I'm really interested in this stuff, or, you know, we've lit a lot of passion fires by talking about social determinants now, let's be honest, for, you know, at least 10 years, you know, so how do we take that and harness that energy, that passion, that motivation that comes out of people when they sit in these types of trainings to really come through and to do something different. You know, you can encourage self-learning, you can encourage smaller pockets of leadership within the defined a bigger picture. This is where you can use things like the journal clubs or discussion groups. They don't have to be face-to-face. They don't even have to be virtual via Zoom. They can be email journal clubs, right? There's a lot of ways that you can find a structure that gives the people what they want and need, but doesn't like end up, you know, being too much of a burden that they're like, I need and want this, but there's no way I can get it. Sometimes that's more harmful to do that, right? Because you tell people, here's a solution that you can't have. Bad. And then finally, use all the available data you have to tell your stories. You know, this is again kind of thinking and pulling at some of those threads within the organizational assessment, but all of you have a ton of information available, and you just need to array that information into data that will be useful conversationally for people in discovery process or as they're walking through their QI projects. All right, so I am 10 minutes behind. So that means that we have a 10-minute delay for Serena. So we'll go, we'll give her the additional 10 minutes. And I'm gonna call Leah. Leah's like, I can't get in. So let me fix that.
Awesome. Well, let me introduce Serena. So y'all, I've known Serena, honestly, I don't know how many years now, 6-ish, maybe something like that. But she's a joy and a pleasure. Serena is an assistant professor in public health at the Zuckerberg College of Health Sciences at the University of Mass in Lowell. She's got more than a decade of experience. I met Serena working on a SPINS project that was very social determinant focused and of interest to people on this call. We were looking at the intersection of housing, stability, and earned income, and clinical HIV care outcomes and retention, biosuppression, things like that. But Serena has led numerous qualitative and quantitative studies across multi-site evaluations. So she is vetted in providing that training in TA with topics that focus on stigma reduction, barriers to care, and unmet needs. This woman is innovative and practical. She's a gem to our systems of care, and it's my pleasure to introduce Serena. Serena, you take it away, friend.
Thanks, Jamie. That's a really nice introduction. Good morning, everybody. Thank you for inviting me to your session today. Jamie and Michael asked me to come and talk about my experience working with SPINS projects and on social determinants of health. And I'm going to, hopefully it's not too basic for you. I have a couple of examples to share with you, but mostly I just want to take your questions and hope take it from there. But so I'm going to share my screen. I have a few slides. So can you all see this? Oscar or Michael, can you give me a thumbs up? Good. Okay. Let me just put this in. Okay. I got a little bit of delay here. Greetings from Boston, everybody. It's so cold here. We just got a cold wave. So when Jamie was talking about spring, I was like, well, flowers are out, but they're also drooping because it's so cold. One other thing I just want to tell you just about my experience. I am also a member of the Ryan White Planning Council here in Boston for our EMA. And so I try to, being part of that planning council really helps me bring the experience that I have in working with projects across the country. I bring that data and that experience to our planning council. And I learn from them about what needs to be done. So just we're right now, some of you may be involved in planning councils, but we're right now in planning our allocations for next year. And we're looking at data, figuring out what our gaps are. Where do we need to do that? And for us here in Boston, a priority is addressing many of the social determinants. One other thing I just want to share with you, why I focus on social determinants and how this impacts returning to care. Mike brought up COVID. I think COVID really exploded this issue for our country, our communities, all of us, as we noticed what was happening with our healthcare system, who was getting impacted, who was dying, all has to do with social determinants. And in some ways, I think that's really good because we've needed this as a country. We've needed to make these structural changes. And I hope some of the things I talked to you today that you all are doing are moving towards sustaining those structural changes that are needed, because we've seen that there are so many people who are suffering from our healthcare system. So let me just say to start off, when I say the word social determinants, what does that mean to you? Maybe you can just put in the chat. What are some examples of social determinants that impact your clients returning to care? What do you think some of those pieces might be? Oh, I have to open up the chat. Let's see. Okay, transportation, housing, yes, poverty, access. Access, big piece. Let's talk about what access is. Age, substance use, mental health, excellent. Lack of resources, race. Yep. People experiencing eviction, transportation's a big one. Yeah, those are all great. So here's a definition that I like to use. It's from the World Health Organization. And social determinants of health are conditions in which people are born, grow, live, work, and age. And the reason that I like this definition is because it shows the life course, and that these social determinants may change over time, depending on where we are and in our status as we age, where we're born, what our race is, what our gender identity is, which may change over time, where we work, those, what do we have access to? All those, if we stay in the same community, maybe they don't change as much. If we move, it might change. It might be different for us. So this definition is all incorporating across our lifespan, across the communities that we live. Sorry, I'm having a delay. There we go. Okay, and so some of you already mentioned these, but I just wanted to give you a high level of how social determinants actually impact health. And I'm taking it from, these are familiar probably for many of you, for people living with HIV. This graph comes from the Kaiser Family Foundation, and I like it because it really shows all the different elements that we might not always think about. So one being economic stability, and I know people talked about employment, but economic stability is even more than that. Employment, income, what I'm taking in, but also how much I'm spending, how much debt do I have? Do I have medical debt? And what kind of support do I have that helps me increase my economic stability? Another big component is thinking about where we live, the neighborhood, the physical environment. And many of you mentioned housing and transportation, right? But also on a larger area, do I have access to parks or playgrounds? Is it walkable? Can I go out into my neighborhood? Or is there an increase in gun violence right now? So zip code, geography, all of that impacts too, where resources are going from state and federal level into certain geographic regions, and what housing, what parks, what the walkability, the safety of that environment is all important. And those are social determinants. Education, if I'm someone who's foreign born, a recent immigrant, how well do I read and understand English? But also from other aspects of growing up, literacy. What is my literacy level? Can I understand how to take my medication? And that all impacts where I went to from my childhood education, early childhood development. What was I exposed to? Do I have opportunities for higher education, vocational training to improve my job skills? Food, another important social determinant. Am I able to put food on my table, and not just quantity, but quality? Do I have access to healthy options, or am I eating fast foods, processed foods that are impacting my health? Because often they tend to be cheaper. Then your community, your safety, your social context, your social support. Who do I have? What's my friend network look like? What's my work system? What kind of support systems? How am I engaged in my community? Do I live in a community where there's high exposure to violence, which creates stress, or where there's I'm being harassed by the police? What does that look like? And then the other big piece is our healthcare system. People mentioned in the chat access to healthcare. And so we think about this piece as a social determinant. Do I have insurance? I mean, one of the nice things about Ryan White, payer of last resort, right? Everyone who lives with HIV should have access, should not have to worry about coverage. But we do know that in certain states, sometimes there is. Maybe you have to have, Ryan White will pay for co-pays for medications, but you might have to put the money out front, and it takes time, and that creates stress, right? What kind of coverage you have. The quality of care. Do I have access to a provider who understands what it's like to live with HIV, or what it's like to live with a mental health disorder or a substance use disorder, or to be experiencing unstable housing? Or do I get dismissed? When I walk in, does someone speak my language? So these are all aspects of social determinants that then impact you. What I have here at the end is, in this case for HIV, we often talk about viral suppression, right? But I also want to say to think about not just the clinical, the viral suppression, and I have to tell you, I'm trying to move HRSA to think that way as well, but well-being, because it's also about the viral suppression, but your physical, mental health, well-being as well. And that's really important. I also on this graph, I just want to, I added technology. This is emerging, and COVID showed us this. And when I mean technology, not only access to, like what we're doing right now, having a good internet connection so we can meet virtually. I can meet with my doctor, I can meet with my therapist, but also just having access to a cell phone that has minutes available. Do I know how to use those technologies? We're finding that technology is very important in terms of improving people's health outcomes as well. So it hasn't gotten put into the system yet, but it's something that's emerging. Anybody have comments on this or something that I feel like I missed when we think about social determinants? Clear? Okay, I'm going to keep going. I can't see you. I just want to show you one other and to make a case for as you work on your QI projects. Why focus? And this comes from COVID-19. This is data from last year. And you can see from this graph that the COVID-19 really impacted households across America. You'll see that those who reported in a national survey looking at adults who reported having hard time just paying for household expenses and keeping up in the last week, more than half of adults surveyed. And you can see it runs across racial and gender households, but hardest hit were households of color, Black and Latino. Women, female-headed households were hit hard, more than half. And then in the younger and working age adults were all hit hard. And those who had a kid in the household, even more pressured on hardship. So COVID, as I mentioned, as Michael mentioned, really, and you may be seeing that with your clients, you may be hearing that with your providers, that it's really an important topic. People are living this and experiencing this now. So I just want to talk and give you a couple of examples related to my work in housing. One of the areas that I've been interested in is how do we bring these multi-sectoral services together. So it's not just healthcare, but how do we bring housing, employment, social support, behavioral health services integrated? We've been working on it, but there's still a lot of silos. I know that's probably some of the projects that you're all working on. And when we think about housing, specifically, what we tend to think about just stability, getting a physical place to live, right? That I have a shelter, I have a roof over my head. That will help. And there's a lot of good evidence that that has helped. Those who tend to have more stable housing have better health outcomes. And I'll show you some of the work that we did in a minute with the SPINS project. But it's also not just about that, but quality is important. You know, is it in safety? Do I have a house? Is it free? Is it safe to live in? Is there enough room, enough space? Does it have exposure to chemicals that impact my health? Is it affordable? Can I pay for it? Or is it that, especially if I'm living on a fixed income like SSI, can I afford to pay the rents? And we know perhaps in the Dallas region, if it's like Boston, things are just skyrocketing with rent. And you may see with clients, more and more their fixed income is going to that. And then of course, as I talked about, the neighborhood as well. So housing has a lot, it's not just about getting a physical roof, but these other aspects are also important on impacting. And that's something to think about as you explore some of these projects. And how do we bring that in and train our case managers and our staff to think about not just physical, but the quality of that and the location. So
Hey,
Oh, go ahead,
Hey,
Jamie.
I don't want to interrupt. I want to just also keep track of time. So we've got maybe about 2 minutes.
Oh,
If
I'll move
you want
fast.
to, I don't know if you want to give one of your examples, or we'll be providing the slides for everybody. There's only a few left, but I just wanted to give a little clock reminder. So
Thank you. Sorry, I should be faster.
You're
That's
doing
okay.
great.
So this comes from, how many of you have heard of the SPINS projects? These are all funded by Part F. Maybe some of you have had them as well, but Part F, Ryan White, they take, they give funding to allow to try something new in your areas. And so I encourage you to look for Part F projects, SPINS programs that may allow you to try out some new areas and improve your services and health outcomes. But from some of the lessons that we found from the HRSA SPINS building a medical home, these are some of the lessons that we got. One is that we have to think of ways, if you're going to address people with HIV who are experiencing homelessness, you got to get out beyond the clinic walls. It's not bring the people there, bring healthcare, bring services to them. In terms of transforming the healthcare system, we need dedicated, I call them community health workers as part of the care team. Our medical case managers are great, but they're often overwhelmed and working on very specific tasks. So someone who has time to go outside, a navigator, a community health worker, very important to the team. And how do you build that in and ensure that there's sustainability? A lot of times these aren't, they're grant funded positions, but how can we build those into our Ryan White programs? We need more, we found system level coordination, bringing your providers together to the table was really critical. On housing, health, mental health, providers sharing that data, who's getting services, who's not, how do we get somebody out there to bring people back in? On housing, partnering with landlords, that was really critical. Going to the private sector might not be your traditional HOPWA. Think about who are the friendly landlords and hotels hotel owners that you can make partnerships with and get people housed. And then we also found, going back to technology, cell phones are really important. Just because people have, they may be experiencing unstable housing, phone is a critical way, and cell phones to keeping them engaged. Okay, I'm gonna go really fast now. I'll send these slides, but basically what we found is we found in the end, if you look here, these programs that came up through the SPINS initiative actually improved viral suppression. We've started at a baseline of 49%. The 77% got virally suppressed who were stably housed. That's the gray bar. But even those who remained unstably housed, their viral suppression increased just by having this coordination and this extra team member. Very important. Another project, I know I'll probably have 1 minute, Jamie. If I can have 2, I'd really appreciate it. I'll go fast. Okay. Another project that Jamie and I were just working on and looking at another social determinant was around employment. So working with people who are experiencing unstable housing, but also needed employment opportunities. And we had three main strategies: dedicated navigators again. And then we built community coalitions, bringing in the employment sector, bringing in people who are looking for jobs, helping people get job training, because that was a piece that's missing. A lot of them worked through agencies that were funded through Department of Labor, brought them to the table with Ryan White providers. And then also at the organization and at the health department level, we started integrating measures around employment and housing, getting people, making sure we were tracking it and asking the questions of clients every time they came in. How's it going? What do you need to improve your skills? Have you found a job? What can I do to help you? These are all important pieces. So if you start tracking it, then you know you can start putting resources into it and filling those gaps. This is one example just to share from a client who was struggling with a determinant. She was a woman from Central America, was one of our clients. She was undocumented. Her husband has passed away and was trying to raise her children. She needed she was very entrepreneurial and she needed access to do something to bring income into her family. And the navigator worked with her to figure out her skills. And she started a cooking business. And then it grew to a catering and she was able to support her family. So the point is, even with this social challenge of being undocumented, how can you work around the system? What can you do? And promoting that. And that's where we can think outside the box. So in my last minute, and I'm sorry I've gone over, let me just, a few lessons to think about on your quality improvement, what I've learned. And you're maybe already doing this. One is involve people with the lived experience and as you design your projects to help you think about what works, what closes the gap, what is important to measure, and what data to be collected so that we know it's impacting their lives, their well-being. Think outside the box, just like that example I gave you with helping that woman find income through selling and preparing and cooking meals for people. I've already heard it from Michael. It sounds like you're doing this, creating opportunities, peer learning, just like that, what you're doing here. We have cohort calls for navigators on the SPINS project we work. So we do them by staff per se, so they can talk and share ideas. But then we also bring multidisciplinary teams together, particularly to address complex issues like intimate partner violence and stigma. And those meetings really need to be consistent, virtual, or in person if you can do it. And then rotate leadership and facilitate so that people can bring their experience in cases, and it promotes leadership and you get new ideas. Sharing that data, I hear that's what you're doing. And important, not just share it, but think about those successes. What was great? Highlight yourself. This is great. And then say, here's our challenge. This is where we're still faltering, and bring it back to your peer learning groups. This has helped us. And I've seen people who, like, for example, want to improve their enrollment and outreach to particular populations. And the last thing I just want to leave with you is, have patience. Changing these structures and policies around social determinants takes time. Our healthcare system here in the US, even our Ryan White system was not built. It's built to say increase viral suppression. That's great. That's what we want to do. But all these other factors, these social needs are what's important. That's going to influence that. And so we need to think about how do we build projects that are addressing those that can then lead to those health outcomes. So I'm out of time. Let me just tell you, here's a website. I don't know how many of you use Target HIV. Maybe you've already done this, but there's a whole list of SPINS projects there that have manuals that you can look at, specifically how to address homeless populations, how to improve employment, how to reach other specific populations such as transgender populations, young MSM, women of color. So my contact information is on the front of the slide. I'm sorry if I went over. I hope this was interesting and useful, and I'm happy to take questions.
Hey, I'm seeing lots of positive vibes here, and we also are getting the positive vibes in the chat room. And what did I say before? Give the people what they want. So they wanted some Serena, and that's what they got. And we're so glad to have your expertise shared with us. And you took me to church as a person living with HIV who's very passionate about social determinants of health. And thank you so much. Just in the interest of time, I do want to introduce Leah so that we can, we might not have time for the breakouts now, but that's okay. We can have more of an open conversation, but it's my pleasure to introduce Leah Hopper. She's the Executive Director of AIDS Ministries and AIDS Assist in South Bend, Indiana. I hope it's okay that I added those details, Leah, to your slide. I met Leah working in Indiana a couple of years ago. And one of the things that always struck me about her is her incredible energy and enthusiasm and her passion for the community and focus for the population and for our people. It's just always been so inspiring and touching to me. One of the things that's also encouraging and inspiring about Leah is that she's the executive director and she's also a care coordinator. You know, she does and understands all the different roles and activities that happen in her organization. And I think that will resonate with some of you that operate in smaller shops just a little bit. She is, as I said, passionate about social determinants of health, community health, populations, and telehealth. And I could keep going on, but I'm gonna turn it over to Leah to talk, and just let me know when you want to advance slides.
Okay, thank you, Michael. You can go to the next one. So like Michael said, my name is Leah. And so I just wanted to give a brief background on our agency so that you know where we're coming from when I do talk about technology and how it kind of works for us. So our agency is located in South Bend. If you are unfamiliar with that, we are just about 2 hours to the east of Chicago. So just a little bit of the northern area. We serve 9 counties in north central Indiana, 7 of which are rural. So our population is very different than the majority of the state. And 52% of our clients are people of color. With, I would say, I think we have 12% direct from Africa. So we do have a vast mix of clients. We provide a plethora of services. We are only Part B funded. So that's also a big thing for us. And our clinic is all telehealth. So that too, we are huge in technology. I love technology, minus social media. I'm not a social media person, but we do a lot when it comes to technology. And then we not only do we serve people living with HIV, but we also serve the community. We are co-owner of a community pharmacy that is located on site. And then we are the STI provider for our area as well. Next slide, please. So tablets. Tablets are my favorite thing ever. When we were able to get tablets back in 2020, when COVID came, we were initially awarded a pilot of just 10. And before I signed my contract, I said, you can just go ahead and bill me for 40, because I knew I was going to somehow find a way to get more money for tablets, because I knew these were going to be a hit with my clients and with my staff. So we've used our tablets to do a lot of different services, and over time it's kind of evolved. So when we first got our tablets, we came up with a policy on who was going to access them first. So the first ones we decided were anybody who did not have access to a phone, because during COVID we had to shut services and go completely remote. So we made a list of prioritizing our clients, those who had no communication with us. So anybody who didn't have a phone was our first ones who got a tablet so that we could access. They would have access and allow communication. Our second one was any client who was in our rural counties. They were the next ones to receive it. And then our third one was anybody involved in any medical or mental health care that needed to reach any of our providers to do telehealth visits. Those were our third. So that was how our list of priorities went. And then after that, it was for any client who wanted to receive services. So through our tablets, when we first started, we were only doing case management, telehealth visits, and then housing inspections, because at that time, we weren't able to go into the houses to do housing. So we had an admin tablet that our transportation drivers would take to the inspections for the apartments, and they would walk around and we would do an inspection. So we were doing inspections that way. Then as COVID progressed, we decided, well, we need to start getting engaged, more engagement. So we added life skills classes, support groups, a GED class. We do yoga and meditation still every day with our clients through the tablets or any virtual capability. So we do it through Zoom. And then we worked with Continuud to design different, so our platform looks a little different than most because we added a survey. So every 3 months, we have our clients take a survey and to assess their mental health. We also have these admin tablets that we take out in the field now for testing. So all of our prevention testing is done on a tablet. We have other things added as well. So they have games on there that they can do. They cannot get on social media on our tablets. It is strictly for mental health and wellness. They can do Zoom, they can get their email, they can do all their visits. That's all there. And we have, our support groups check in, anything like that. Then now we have added our transportation logs. So we have drivers and they log everything through our tablets as well. And then this has also allowed our clients to be able to participate more in our CQI projects. So we run focus groups every other month, and all of our clients are now able to log in. And if they don't have a tablet, then we can provide them with one just for the day to do these groups, and then we'll go back and pick it up. So they don't have to always have the tablet with them. We keep 3 admin tablets in our office at all time for our transient clients so that they can come in and do visits, or they can check their email, anything like that. So the admin tablets stay in our office and so that they're not lost by the transient population. Next slide, please. So besides our client tablets, we also have a kiosk. We currently have 3 more ordered because the pilot one that we did was a partnership between Walgreens and ourselves. And we put it in our HIV Center for Excellence Walgreens. We found it probably wasn't the best location. It hasn't received as much traffic as we thought it would be. However, it is screening people that we didn't think would otherwise be screened. And I say that because where this Walgreens is located is in the more affluent part of our town and not necessarily the part of town that where populations we'd like to be screened are. But it is doing its job. It's very discreet, it's convenient, and it allows for us to get more people screened. So through our kiosk, you can screen for HIV and STI. You can have your test performed at the Walgreens, or you can select to come to one of our offices or do a door drop test, which means we'll bring the test directly to your home, and you can be tested right there in the convenience of your home. Our new tests, however, are not going to say, or our new kiosks are not going to say free HIV. It's now just going to say health screening. We're going to have more screenings available. And then it will also have a QR code on there. So that way you can just scan and walk around the store and take the screening instead of having to stand there at the kiosk. So we have made some modifications to our new kiosks. We also learned that they're not always going to be in a Walgreens because not everybody goes to Walgreens. So we looked at other locations to put them. Our next one is going to be in a Walgreens because it's going in one of our rural communities, and that's the only place that would put it. But we are looking at putting the other one at, it's like a community center in one of our more parts of town where it's a Hispanic community. So we're going to be putting it over there. And so it will actually be bilingual. So yeah, so we're really excited about that. And I think my next slide, and I think I'm done, actually. I think it's just my contact. Yeah, so if anybody has any questions, I would be willing to answer them. I love the tablets, so anything about that. I will say, so we have an onboarding system when we give them to clients that I could talk about too. So we have one person designated that goes out, gives the tablet to the client, goes over it. We have a contract that our clients have to sign about if they lose it, what happens. Our tablets are allowed to be replaced twice without them having to file a police report. But if they have to be replaced more than the twice, they have to do a police report for us. They can't damage it, like there's all kinds of restrictions. We have had the police confiscate our tablets before, so I've probably been through every scenario known to man about the tablets. Yeah, but yeah, they're great. They're a great thing. We've had clients, go to church on the tablets, complete their GED. Look, jobs are a big thing, so we can do job training on there. Yeah, we do financial literacy, set up bank accounts, everything. We just do it right there on the tablet with the client. So yeah.
So was I right or was I right? Wow, 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 wow. And especially when you put the 2 presentations together, I hope that we've unlocked, some thinking for all of you. I'm seeing a lot of positive reactions in the chat room. And since we have about 16 minutes left of our scheduled time, I don't think it makes sense to try to scatter off into breakout groups and to come back. And rather, it's better to just have an open conversation with folks. Now, Dr. Salinas, how many continued tablets does a county have available for folks to, request and for us to put in the field? Because I think that this is, why not jump right on it, right?
Well, I think that it's a great opportunity, and that's the purpose of that. Bringing Leah into this is open eyes, look at opportunities and diversify. We have 28 tablets available for recipients who want to expand the project and connect it. I mean, it's completely open. Let's chat about it. Let's talk about it, and let's put that in place for the benefit of our clients.
Linkage to care, rapid start, social determinants of health. Like, oh my gosh, I like, the idea of doing the prevention stuff through the tablets, like in third-party sites, is just incredible in terms of leveraging public-private partnerships and relationships. I'm wondering if this has spurred any thinking for any of you on the line in terms of, potential in the implementations, and if there are any questions or kind of concerns. Leah had offered to talk a little bit about, how they came up with their priorities and how they distribute. We know that that's been a barrier for some of you here. So we just wanted to open it up and see what some of your thoughts are.
Thanks, Regina. I say 28, not 58, but in case we need more, yeah, we can request more if that is the need. Yes. And I do have a question for Leah on the sense of reporting. Let's say someone is in the field doing the delivering the services, let's say outreach, that person type access the client when that person is getting into the system. What system did you merge? You merge on site, or you have to go back into the clinic and do the sync into your system, and that fed the electronic medical record? How that plays in that case?
Yeah, so for our testing, we use Acuity, the platform Acuity, which Continuud upload all of our testing forms into for us, and then it just sends an email of all the completed forms back to the director of the program. And then they just print them off, and then we can use them because Indiana's a little late in the game and we still use paper forms.
Okay, so it sounds like it's as automated as it possibly can be.
Yeah, and Continuud set up a lot of things for us, and then it just gets emailed. It's all of it back to us, either in the Google Drive or directly to our email, depending on if it has to be like secured because of a name or not.
Do you feel any, icky about HIPAA, about that detail and security?
No, because in the Acuity testing platform that we use, the patient is already putting their name in there. So they're already signing a HIPAA consent that we're getting that information. And the only way you can get into our tablet is with a password. So you can only access that system if you put in one of our passwords. If I then shut that system down and gave the same tablet to a client, they wouldn't be able to see any of that information that's in the testing platform. That's why we can use the same tablet, admin tablet, for both programs, for both a client appointment and for a testing appointment, because they can't see any of that without a password. It's very secure. Everything is so secure. Even when you give a tablet to a client, the client has to put in, something with all those dots, some type of code to open it up for themselves. So it's very secure. I wouldn't, yeah.
Leah, I liked hearing about how you had sort of a process of identification for who's going to, let's start with folks with no phone and work through that. So I liked hearing that was a process piece. And then I also liked, all the things that are accessible for folks. So 2 questions. Do you have any type of resource you could share with us where you've maybe worked through how do we identify people to give these to? And then tell us a little bit about how you orient them to the tablet when they get a tablet, because I know that's been a challenge. And it looks like you're using your tablets, like you said, for attending church, for many other things. So how do we get these resources in the hands of people where they feel, a certain sense of command over what they want to use it for?
Yeah, so I can send all of my SOPs that we have regarding the tablet, because we do have I have a very good writer for those. So yeah, I will send all of our tablet SOPs that we have. It details the exact structure that we use to select our clients for that. So I will send that. And then as far as our onboarding process, we have an SOP for that too, so I will send that. But what we selected one person who happens to be one of our retention and care is what we call them. They also do some driving for us. And then so they go and onboard our clients. They will take the tablet, the contract, they'll go over the contract, then they sit there and they show them how you do the code to open the tablet. They set up their email with them. They set up their Zoom account with them. And then they will actually practice doing Zoom with them. So once everything is set up, they use their cell phone and they'll do a Zoom meeting. They will send them the email with the Zoom link, make sure that the client can get into their email, open the Zoom, and then they will have a Zoom while they're sitting next to each other, just so that they can engage in the process and know that the client is comfortable doing it. And it usually takes about an hour, I'm not going to lie, to go through everything. And that is just to make sure that the client is comfortable. Because I will say some of our clients who were given tablets were older population who didn't know how to use technology when all this started. And so there was some barriers there. We also have some clients who are lower functioning and needed some additional help. Our retention and care goes back a few times because we've had clients who have taken their email off their tablet or can't figure out Zoom again. So, I mean, it is a process. I'm not going to sugarcoat anything. You have to keep working with them with the tablet, but eventually they get it. I mean, if they can use a cell phone, they can use a tablet. And I will also say we have on our tablets a calling app where they can get texts and they can call from their tablet. So we have that feature as well, because I do know, I think Serena said something about the access to the phone. And so we do have that so that they can call and text us.
Yeah, Leah, this is Dell Wilson with Resource Center in Dallas. Do you mind saying what calling app you use, or? Oh, not sure. That's
yeah,
fine.
I'm not sure. I'm so sorry.
Okay, thank you.
Yeah.
I really appreciate you sharing about that and that integration as well, because, sometimes just having a phone is like root cause, issue, barrier one, and we overcome that, but then it's, well, I'm out of my data plan, so it's also like considering that. So if the tablets can sort of be used, that's protective against when folks run out of data. And I also want to just bring it back to the stories that you're sharing with us, Leah, in terms of the ways you've used it and how that extra touch point, that hour of time, I'm sure sometimes is a rewarding experience, and I'm sure sometimes feels very labor intensive, but it's that extra time that makes a world of difference. And so I'm thankful for your support in staff and getting that done. And then I also really like how Serena shared stories, for example, the woman who loved cooking. So as we think about these QIP projects, whether it's the experience of staff as you study and adapt or adopt what you're doing, or it's the story of clients, it's really wonderful to hear those and to share those up and out. That helps engage people and just propel the successes you experience and the lessons learned.
Yeah, this is Dell again. I'd like to tell Leah that I really appreciate hearing about all the ways you're using the tablets, because here in Dallas, if the initial purpose, of course, was telehealth, and at the moment, most of our patients are coming in, being seen in person for blood draws and for clinic appointments. But with COVID, we may fade in and out of these periods where telehealth is more prominent with the HIV outpatient care than it is at this moment. So, you know, just the other ideas of how you use the tablets with some of the other service categories, very interesting. Thank you.
Thank you.
Yeah, and Del, you know, you make me think, like, if I can use this thing for my GED classes or for connecting with my faith community and my care, I'm going to use it more, which then builds my skills, builds my command of this tool, rather than primarily for just care related services. So I love how you're baking in advancing folks' familiarity and comfort with technology, because you're giving them a lot of what they want. And then I see Serena's hand. Go for it.
Yeah, I just want to piggyback on that point and what Leah's saying. And I'm working on a project now where, particularly for some people who are just really feel marginalized from the system, the healthcare system, or if they needed access to mental health, the tablets have just been really, for some, a life changer in terms of the social support, the access, attending peer support groups. I work on a project with women who have, you know, experienced just multiple challenges related to stigma and IPV, and they find it, you know, easy for them to, some of them to engage. We have to make sure they're in a safe place that they can use it, but it has helped many people, particularly who've been marginalized from the system so long. So just thinking about that, if there's a particular population you want to work, it might be something to do, something to use.
I like how the tablets kind of cross the bridge of marginalization and working with survivors of intimate partner violence. You know, one of the most important things, really the central thing to do, is to rebuild their choice. And so for someone to have choice, you know, this is how I want to engage, or this is what I'm ready to do. This is what I'm comfortable with. This is what's safe for me. There's just a lot of restoring that autonomy and power back. And so I love hearing how the tablets are also a mechanism for survivors to regain, you know, choice and power. It's huge.
So don't be dismayed. We're not going to close conversation just yet. We have 3 minutes left. But what I want to do is I want to launch the evaluation just so that we can collect that. As we noted, this is our first time doing one of these new format sessions where we have guest speakers who are really coming in from outside of our system to help enlighten us in our thinking and to be disruptive in our thinking, you know, because we, you know, sometimes get stuck in our rut about what life is like right here. And we heard 2 incredible presentations from different parts of the country who have some experiences that are very much aligned with our experience here in Dallas, and some things that are a little nuancy. But we're really interested in hearing your feedback on whether or not we hit the mark here on providing you with interesting food for thought that you can use in planning your next steps for your quality project. So sorry for the words, but I definitely wanted to draw your attention to the evaluation, not to cut off the conversation. You know, in terms of here, oh, go ahead, Dr. Salinas.
It seems like it's populated. I mean, I've seen the evaluation, but it's already populated.
Yep, they're coming up. They're coming up. We have, almost everyone's already participated. Thank you.
And I just would like to add for those who are like thinking about the budget and spending, all of those services can be done via tablet and is available. As far as I know, there's any no or point of clarification that needs to be done, we can consult back to the AA with Wanda or of course Sonia.
especially when I'm thinking about, you know, we're having Miranda on these calls now to think about like how the system materializes together with EHE in the center, you know, knowing that we have Chris Adkins here from the AATC also, like to really help us to gel our system response, you know, the response pillar for EHE, you know, in the Dallas region, I think is great. Chris, I don't know if you have any reactions to anything that you heard today or any food for thought.
You know, I've seen the poster presentations you've all done, and it was really great to kind of see, you know, some of that stuff as it's been in action and hear a lot of your concerns. And I just wanted to let you guys know, if you need more hands-on TA, that we are capable of bringing in consultants for you and working with you as needed.
That's right, population basis, or it could be on any aspect of how you're trying to stand up your program. And for different audiences too, we're used to in our region thinking about just the ATCs for doctors and nurses and social workers. It's for everybody. So think about how you can leverage that additional resource beyond what we're providing here on an every other month basis. There's gotta be things that are more granular that you can leverage this expertise and to pull them into your activities.
Yeah, and we as an AA, we are so delighted, willing to collaborate along with the ATC in any capacity. So thanks for being here. And Miranda, thank you so much for coming over and giving this time. If you have any words, welcome.
Yeah. Well, speaking of time to thank folks, I don't know, Oscar, if you want to just take us home here, and Sonia too.
Sonia, are you there?
Sonia, can you hear me?
All right. Well,
yes, I'm here.
She's here.
I greatly appreciated the speaker and just seeing the perspective of the tablets on the ground and the other uses. So that was very inspiring. And I hope that we can expand our tablet use in our area as well. So thank you. The session was great. Thank you for that.
Thank you so much. Thank you for your support, Sonia. And thank you every single one of you, and to the speakers and everyone, single one counts. Thank you so much, and have a good week.
Yeah. Enjoy the rest of your day and have a wonderful weekend, everyone. Thank you so much. Talk to you soon.
Hi, y'all. Great call.
Thanks, everyone.
Thanks.